time is a little bit delayed. I'd like to start this session on live case 3, complex PCI. I'm Hong. My co-moderator is Dr. Akasaka from Japan. We have several famous panelists, Dr. Aramsareewong, Dr. Chan, Dr. Flaherty, Dr. Hong, Dr. Takashi, and Dr. Vincent, and Masoumi, and Dr. Nakamura, Dr. Nam, and Wojciech, sorry. And we have 2 live cases from the Asan Medical Center. Dr. An, are you ready?
Yes, we are ready. Good afternoon, Dr. Hong, Dr. Akasaka. So we are preparing the 2 cases of the instant restenosis and then the restenosis case after the PCI. So I'd like to introduce my team, Kyusup Lee from Daejeon St. Mary Hospital, and Sang-Young Jo, our senior fellow. So Dr. Jo, could you introduce our patient?
Yeah, thank you for introducing. Let me start a brief case summary. A 68-year-old male patient who underwent PCI at proximal distal RCA and proximal mid LAD 2 years ago early visited the outpatient clinic due to worsening chest pain. He has been treated with hypertension and diabetes. The coronary angiography showed disease progression of proximal LAD and instant restenosis of previous LAD stent. Next. His past history is diabetes, hypertension, and hyperlipidemia. His clinical presentation is unstable angina. Next. It's a baseline ECG. Baseline ECG shows mild ST depression and Q-wave on inferior lip, but compared with 2 years ago, not significant changes. Next. The not significant findings in chest X-ray. Non-invasive studies. Echocardiography performed 2 years ago showed a kinesia of infero-posterior wall with normal LV systolic function. Thallium SPECT performed 6 months ago, partially reversible large-sized, moderate to severely decreased perfusion in multivessel territory. Cardiac case findings. Next. Right coronary angiogram showed mild tubular ISR at proximal and mid portion. And in the RCA caudal view, the collateral flow to the distal LAD and distal circumflex artery was shown. Next. In the left coronary angiogram, caudal view showed significant stenosis at proximal LAD with ISR was observed. LCA cranial view is next. LCA areocranial view and LCA spider view is as followed. It's end of the presentation.
Thank you. Thank you, Dr. Jo. Do you have any comment or question on patient history and baseline coronary angiogram?
Any comment from the panelists?
When were the stunts placed? I may have missed it.
2 years ago?
2 years?
Yeah, 2 years ago.
Right.
So Dr. Jo, after 2 years ago, PCI patient didn't have any effort chest pain.
His effort chest pain was started 3 months ago.
Okay.
In these images, what is your target for the PCI in these cases? What is your plan?
Yes, thank you, Dr. Hong. I'd like to summarize the patient angiogram, and I'd like to explain my plan. Actually, based on the baseline, patient have RCA total occlusion and circumflex total occlusion, LAD diffuse disease. 2 years ago, we put the stent RCA, but we didn't treat the circumflex and put the stent at LAD. We treated the 2 vessel and remained the 1 vessel CTO. So even after the PCI, even there was one CTO lesion in the circumflex. The patient was doing very well without any effort-related chest pain. Recently, the patient effort chest pain recurred. The angiogram showed that that is due to the proximal previous stent proximal portion tight instant restenosis is observed. Thallium specs show that the large territory perfusion defect of the circumflex territory. So circumflex territory is already total occlusion and so stable status. So I don't like touch the circumflex and focus on the LAD ISR. So in addition, we have to know that the collateral flow, the RCA, collateral from the RCA to distal circumflex and distal LAD. Definitely LAD is very tight and circumflex there is a collateral flow. So it is very important sometimes when we do the procedure, so to decide the simple crossover or the side branch saving, this comprehensive understanding of baseline coronal angiogram is very important. Anyway, I'd like to focus on the LAD, the instant restenosis.
What do you consider the mechanism of restenosis to be here?
Yeah, we reviewed the previous PCI. There is actually two mechanisms of the restenosis. The first is stent under expansion. Second is neo-intima hyperplasia. So based on the previous imaging, we performed the previous PCI with the intravascular ultrasound guided, and final angiogram showed final.
Let me check the angiogram. What is 2 years ago, the circumflex at that time, the CTO lesion with a collateral supply from the RCA?
Yes, right.
Okay. What is the size of the stent and the LAD?
3.0.
What size?
3.0.
3.0.
So if you used ultrasound, it sounds like a drug or a polymer failure. If it was
Yeah,
optimized.
I think so. I'd like to see the IVUS first. Test.
It could also be recoil, but I don't see a lot of calcium to cause that.
So here the antegrade flow is a little bit slow after the wire insertion, but I mentioned that there is a collateral flow from the RCA to the distal LAD. So patient didn't complain the chest pain. We don't worry about the.
I'd like to ask why. I think in this case, imaging examination is very important. However, why did you select the IVUS rather than the OCT?
First of all, as you know, that if there is a tight stenosis, the OCT cannot perfectly flush out the RBC blood, so imaging is not good. So in this kind of very tight stenosis, I prefer the intravascular ultrasound instead of OCT.
But
okay, go ahead.
Either would be okay, though. Depends on your local practice, right?
Because Dr. Flaherty asked about what is the underlying mechanism of the instant restenosis. And then we have to, to answer about it, we have to know about what is the neo-intimal characteristics. What I mean is this is the presentation is unstable angina. It means some possibility of the plaque itself is neo-atherosclerosis. And therefore, more clearly validation of the neo-intima characteristic is OCT is better than the IVUS.
OCT will give superior plaque information.
This is a very important point. Yeah, I fully agree with it, Professor Hong's opinion. So this is IVUS, just distal to the previous stent. So stent is coming. Stent is relatively well expanded, but there is some neo-intimal inside of a stent. We previously implanted a 3.0 stent. Stent diameter looks like a 3.0.
Some calcium?
Yeah, some calcium, some calcification outside of a stent. Diagonal branch is coming from the 1 o'clock.
So at the same time, he has a long stand in the RCA, and clinical characteristic is not like promoting very rapid neoatherosclerosis. So maybe because this is a focal disease, is rather the mechanical problem in this proximal part of the like the peripheral calcium, or the proximal edge of the stent was in the plaque at the time of implantation.
Okay, here is the proximal LAD. Yeah, there is a huge plaque burden. Lumen is not that big.
After the end of the IB examination, please show us the lipid once again at the most tightest lesion.
Yes.
And then we will realize what is the characteristics of the neointima at the tightest lesion. I found a little bit some lucent area.
Yes.
Maybe
right.
some possibility of the lipid.
I agree.
Yes.
Yeah, there's a lot of disease that was not previously stented.
Yeah,
Suggesting
that's
progression
right.
of that disease.
Yeah, proximal LAD, there are many diseases, right? Yeah.
더 타이트한데 좀 보여주세요. 런해 주십시오. 조금, 네, 거기서 런해 주십시오. 네. Here is the tightest portion. There is no calcification, but the radiolucent dark area inside of the neointima. So it looks
Here.
very soft.
Here is,
Here.
Here is some low echoic portions. Yeah.
Yeah.
Right.
Low echoic portion is extended to the outside of the stent. Another interesting point is that the plug is extended to the distal left main bifurcation, and LAD ostium is very tight.
Yes.
Here is LAD ostium. Circle is coming from the 4 o'clock. Distal left main, some calcification. Here is the shaft of left main.
Why do we know about the neointimal characteristics? That is very helpful for the plan for the next step. What I mean is that the neointimal characteristic is that looks like some lipid. It means that easily compressible. If plaque character risk is itself is some fibrotic or calcium, it means that we have to ablate. But in these cases, I think it's based on the image. The plaque itself is easily compressible. And second one is the angiographic appearance in the LAD os. There is some haziness. So we have to deploy the stent on the proximal LAD to the left main. At the time, we lose the chance to the PCI at the circumflex. That is another possibility.
Does anybody worry about the durability of more PCI in this biology, given the rapid restenosis and new disease?
The right coronary is fine despite long stent in the CTO environment, so could be only local.
Yeah. I think it may be important to notice from the previous angiogram whether there's any geographic miss. According to the angiogram this time, this quite diffuse, at least moderate disease starting from the distal left main all the way to the stent edge. Geographic miss is one of the reasons accounting for this rapid appearance of ISR. Otherwise, the other rest of the stent is okay. So probably the details of the last angiogram, if possible, there's any imaging, including intravascular imaging from the last PCI, will be very helpful for us to understand the failure, the quite early late stent failure.
And if you only treat the proximal disease, then you don't ruin future bypass targets.
Yes, I always spare the distal bypass graft location. So anyway, I like to treat the ISR using the stent. Actually, to compare the DCB treatment and additional stenting, overall effectiveness is overall similar, but DCB can reduce the full metal jacket, double jacket of metal. But in this case, a little bit different. The instant restenosis, and then there is some plaque and significant stenosis at the LAD ostium and proximal LAD. So to treat the whole patient to the proximal LAD, we have to implant the stent from the inside of previous stent to the left main. This is the idea. Fortunately, as Professor Hong suggested that the neo-intima looks very soft, very compressible. So after the high pressure ballooning, using the 4O high pressure balloon, and then I like to implant the additional stent. And considering the side branch, actually there is actually circumflex is a very big circumflex, but already the CTO lesion and collateral from the RCA, so I don't care the small residual the circumflex flow. So I just a simple crossover without any side branch jailing wire.
Okay. What is the balloon size and the stent size?
Stent size is actually left main vessel is more than 4O. So left main is 4O. And proximal LAD is also 4O. So high pressure balloon for pre-lesion modification, this is 4O 20.
Non-compliance balloon.
Yeah, non-compliance balloon.
In the instant stenotic region with the atherosclerosis, there is a more possibility of some slow flow or no reflow after the balloon dilation.
Inflation, yes. 8, 10, 8, 12, 4 or 12, 10, 10. Deflation.
Academically and the educational purposes, this is a very educational cases for the instant restenosis. Emphasize the value of the intravascular imaging and the evaluation of the plaque characteristics.
Yeah. As Dr. Hong, yes, already pointed out, the limitation of IVAS is the resolution, right? It's sometimes difficult to identify the plaque characteristics very well compared with OCT, right? So in this case, if we have the OCT image, we can speculate the mechanism of this restenosis.
A little bit beyond the expectation. What I mean is that after the balloon dilation, I imagine that there is no residual stenosis, but the angiographic appearance a little bit narrowing.
I will get another view also to make sure that we can see in kind of more of a comprehensive assessment.
Test. Ready?
Cranium.
So I use the 4O high pressure balloon. So proximal stent is dilated further than the mid portion of a stent. So the mid portion of stent looks smaller than proximal portion, so looks tight, looks stenotic. But I'd like to apply again the mid portion, one more. 10.
And meaning that you dilate this region with a 4O balloon, it means that the previous stent size selection might be a smaller.
It was 3 before on IVAS.
Deflation.
So you're taking everything bigger.
Any role for cutting balloon or scoring balloon up front?
So, Dr. what is your idea for the cutting balloon or scoring balloon to treat the stenotic lesion?
I think it depends on if you're going to re-stent the affected area or not.
I think the angiographic result is quite decent after the just pink balloon, high pressure balloon.
It gave pretty
very soft neurointimal hyperplasia, not just that calcified or very tough fibrous
Run, please. So
would you
I like
advance
to do,
the IBIS caster more distally? What I mean is that the more distal, we realized what is the real vessel size.
here is distal to
Okay.
the stand. Here is vessel size is not that big. Here is so distal vessel is 2.5 or less than 3.0, but the stented side vessel size is 3.0, and vessel size is more almost 4.0. It may be associated with some kind of positive remodeling after stenting.
Another reason, the small vessel size in the distal to the distal stent margin is that you mean that the flow is much improved, impaired, a little bit the shrinkage. So that IBIS finding is not a real situation.
Yeah. So here comes the most tightest portion. Balloon angioplasty works very well so far.
Would anyone consider drug-coated balloon for this segment, or just fresh stent?
Yes, just if the stenosis is just placed located in the in-stent, then I prefer actually the drug-coated balloon only treatment. But let's see how is the LAD osteum and distal left main bifurcation calcified LAD osteal stenosis.
Agree.
There is some plaque proximal to the stent. Probably it was landed in a heavy plaque burden before, so probably needs to be treated again with stent.
Yeah.
With the crossover to left main.
Stop.
So the ostial lumen is not bad. So maybe you can choose the DCB also.
Yeah, I fully agree with your opinion. DCB could be the one option. But to treat it perfectly in my sense, so I'd like to implant the stent, 4.0 stent. 32.4.0 stent, please.
Another value for the intravascular imaging in the instant restenotic region, if the Professor An do not use the imaging, maybe what is the stent for these cases? Maybe based on the previous the procedure, maybe he select 3.0 or 3.5 and makes the final balloon size, the high pressure in the 3.7, and that's it, and finish the procedure. However, he used the imaging, he have confidence to select the 4.0 big size of the stent. Still, there is a risk of the population might be smaller. He have a very strong confidence of the imaging finding.
Yes, correct. Test.
Yeah, would you agree, Dr. Hung, that all restenosis should be imaged?
Test.
But I know you image all PCI. Anyway.
Test. Okay. Test. Okay, perfect. Inflation. 11.
11.
12.
I agree with Dr. Ang that super tight lesion like this, you may not be able to obtain good OCT image, but I think OCT is still very useful in determining whether we should place more stents in this situation. So maybe we could, at the outset, use a 2.0 balloon pre-dilate and do an OCT
16.
image. There are different strategies. You may just treat the ISR with DEB instead of putting in more stents, cutting balloon followed by DEB, instead of treating the moderate, osteo to proximal LAD moderate disease lesion, as this is a very diffuse disease entity. We don't know whether putting in longer stents would do more good to the patient or not. And of course, to treat the patient with very high dose statin plus PCSK9 inhibitors may be better than putting in more stents, because he may come back with ISR again. As you can see in the RC, there's also ISR.
Yeah, I agree, especially if the circumflex was a real valuable artery here, you might take that strategy to avoid stenting across.
Yes. Circumflex flow is getting better than before, and in addition, No, I was pleased. I mentioned before that there is just collateral flow, the RCA to the distal circumflex, so I don't care the circumflex. So just focus on the left main to LAD crossover without gel the side branch wire. Patient is stable. Let's see again the IVUS. Actually, I did many IVUS pullback, even in the simple lesion treatment. I believe that the intracoronary imaging, the evaluation, the improve the patient clinical outcomes. Because actually the PCI is our routine daily practice, but the patient side, the PCI is only one procedure in their life. So to avoid the further treatment, so I'd like to measure the evaluated intravascular imaging to make my stenting more optimized. So here is the proximal portion. I implanted the 4O stent. I think I can apply the 4 high pressure balloon. Okay, we can apply the 4.5, but I think 4O is quite enough. So some operators apply the high pressure using the stem balloon, but I believe that the stem balloon using even though 18 atmosphere, 20 atmosphere, it is not the high pressure balloon dilatation compared with the real non-compliant using the non-compliant balloon. So
what is the minimal stent cross-sectional area at the proximal LAD and the left main?
Yes, I will measure the proximal LAD MSA. Give me the high pressure balloon.
Looks like more than 10. Looks fairly big.
Some eccentric, maybe the arsenal of the circ. No, LAD.
Okay.
Okay.
8.5, so more than 5 or 5.5. So definitely the minimum stent area concern, the minimum stent area is above our criteria, 5.5, around 5 or 6. But to make because the vessel size is big, so anyway, to reduce any chance of the future restenosis rate, I'd like to apply the high pressure balloon because the stent is 4O, vessel is more than 4O.
What size of the balloon?
4O high pressure balloon.
10.
10, 12.
12.
14.
14.
After the post-dilation, please show us the IBC examination before and after the high pressure balloon at the minimal stent cross-sectional area portion.
Yeah.
14.
18.
18.
20.
20.
Deflation.
You can see there was a little waste. There was a little waste there on that balloon.
20.
So
22, 24.
24.
Around 10 this time.
Okay. No waste. Deflation.
Without the angiogram, or when we 24. Just look at the fluoroscopic image of the stent, it looks like a very huge lumen.
No, the runoff still matters.
Yeah, you can see the huge lumen.
Very good.
Let's look at some changes in the minimum stent area at the proximal LAD by IVUS. Proximal LAD minimum stent is bigger and no position is good, expansion is good. I'd like to finish my procedure and taking the final angiogram. Okay, here. Run, please. 4O stand here. I apply the 4O 10, 14 atmosphere. Look at the, even though the stand diameter is around the 3.5, not completely 4O. So that's why we need the high pressure based on the imaging.
Here is it. Here is it.
I applied the 4O high pressure balloon up to 20 and 22. The for left main, I applied the 24 atmosphere.
Much bigger.
Yeah. Yeah. Huge left main, huge proximity. I believe that his chance of restenosis would be
Excellent.
less than 1%, I believe. Test, please. Nitro.
Well, it's probably more than 1%. It already restenosis the first time.
Nitro, please.
네.
Could you show us a spider view?
Yes, just a moment. After the nitro, ready?
네, 준비됐습니다.
And I don't think there was a technical error on the first PCI. It was just
Stop.
recurrent disease.
Ready?
Okay. Excellent.
So I like to finish my procedure.
Okay, great. I'd like to say that this is the educational cases for the imaging guided PCI in the instant restenotic region. This is a really typical cases. Great.
Congratulations.
Thank you, Professor Hong. Thank you, Dr. Akasaka. Professor Kang is preparing the second live cases.
Okay.
Second live cases is more tough than my case. Please
Okay.
enjoy.
Congratulations. Dr. Kang, are you ready?
Yes, we are ready, Dr. Hong.
Okay, please go ahead.
Yes. Good afternoon, ladies and gentlemen. I am Dr. Do-Yoon Kang from Asan Medical Center. My team, Professor Jung-Min Lee, in the Eunpyeong St. Mary Hospital, and Dr. Park, our senior fellow, will join the procedure. And Dr. Park, can you please show the case?
Yes, my name is Young-Sun Park, and now I'm presenting the second live case. 63 years old male who underwent PCI at left main and proximal LAD 4 years ago, admitted for newly perfusion defect in the silent spec. He has been treated for hypertension and hyperlipidemia. The silent spec showed newly developed reversible large defect in the circumflex territory. The coronary angiography showed disease progression of left circumflex ostium and ISR at LAD. Therefore, revascularization was planned for this lesion. He had previous PCI 4 years ago, and he had 2 stents in there. Next, please. And he had hypertension, hyperlipidemia without diabetes, and he was ex-smoker. And clinical presentation was stable angina, which was CCS grade 1. Next, please. The ECG showed normal sinus rhythm. There was no Q wave or ST change. Okay, next. And the baseline chest X-ray showed no cardiomegaly nor pulmonary edema. So with done non-invasive studies, the echocardiography showed normal alveolar systolic function, and there's no regional formation of normality. But the silent spec showed reversible large size decreased perfusion in circumflex territory. And next one, please. And this is the previous final angiogram after the first PCI. There was 2 stent, and the stent was patent, and the circumflex ostium there was no disease. Next one. And this is the recent angiography. The RCA showed no significant disease, and the left coronary artery disease at caudal view shows severe stenosis at left circumflex ostium. And next, please. And there's also mid-LAD, ISR, and LCA spider view shows severe stenosis at left circumflex ostium. This one. And we plan to target in left circumflex ostium and LAD or ISR with IBUS.
Thank you for the presentation. In summary, the 64-year-old male patient underwent left main to LAD stenting 4 years ago. It was very calcified lesion. We did the root ablation. And at that time, I was with him. He was my fellow at the time. So I called him back. And after 4 years, and with the thallium SPECT abnormality, he went back to coronary angiography. Actually, we published the post-PCI trial that compared routine follow-up stress testing versus just medical therapy by the symptom last year in New England Journal of Medicine. And the results showed that routine functional test follow was not associated with the better clinical outcome. But the patient was scheduled for myocardial SPECT before the post-PCI result, and the patient went to the cath lab. And now patient has the mild symptom, stable angina with the CCS1, and it shows that typical ISR of the left main crossover stent. In our previous report, about 70%, more than 70% of the ISR in the left main happens on the circumflex ostium. I think that there is severe calcification in the circumflex ostium, and it can be a hurdle to overcome. Do you have any comment or opinion for this case?
Can I confirm the initial stenting, right? Did you do the kissing balloon at the bifurcation or not?
No, we didn't.
You didn't, right? Okay.
Yeah. With a crossover with a 3.5 stent and apply 3.5 NC up to very high pressure with imaging guidance, and we confirmed the good expansion at that time. And circumflex ostium was very clear at that time.
Yeah. What the reason why I asked you, because the tissue growth at the side branch orifice is sometimes a little bit complex, and the guide wire cross at the time of stenosis is very limited, right? So therefore, if you have enough stent strut treatment at the time of initial PCI, it might be much easier to cross the ideal cell. That is the reason why I asked you, right?
But just to open the struts to facilitate retreatment then?
What is your treatment strategy?
Yes, for this patient, actually, there's some mid-LAD ISR. I treated it following your instruction to Dr. An, and I will now concentrate on the left main. Actually, there is a very severe stenosis at the just ostium of the circumflex, and it looks calcium. So I will wire and balloon and will evaluate the lesion with the imaging. And I think I would should place the stent at the circumflex ostium to circumflex. Can you please show the next image?
Although there's also a lesion after the second marginal.
Yeah, that's the problem, I think. The first obtuse marginal branch looks okay, but second obtuse marginal branch, the opening looks not so good at the caudal view. In spider view, it was much better, so I will evaluate it also. Next.
There's also a lot of calcium at the, especially at the lateral aspect of the stent in the left main. So do you think it can be secondary stent collapse due to the calcium burden from outside?
Oh, yes, that's a very good point. I think that the outside of the stent, the calcium grows, and that would make the burden of the circumflex ostium. I agree with the opinion.
I think you may be right. The stent angiographically looks a little narrow at that point. Either it didn't expand fully or it got compressed.
Yeah, it can happen during the 4 years of the calcium growth. And next, this is the cranial view. And next, actually wiring was not difficult, and I treated the LAD ISR. We checked the IBUS first. Can you please show the IBUS? This is the IBUS pullback from the stent distal the stent edge was a little bit mild disease, but was okay. And you can see the mesenchymal hyperplasia here with a little bit on the expansion. It was the tightest portion at the index PCI that we needed root ablation. And still you can see the stent is a little bit on the expanded, less than 3.0. And the proximal, the stent is clear without mesenchymal growth. And here is the osteo. You can see here. The stent size is large. This is 3.5 stent. And the proximal, there's mesenchymal growth. And circumference comes from the 10 o'clock side. And left main, it's okay. It looks okay. And for the circumference, I could not approach because of the heavy resistance. And next, and we treated the LAD with the compliant balloon, the scoring balloon, next. And NC balloon 3.0 up to very high pressure, next. And 2 minutes of the DB here, and checked that the lumen is clear. And I will move to left main bifurcation, next. First, I tried next, oh yes, this is the result after. There is still some narrowing at the site, but we did our best with a very high pressure NC. And actually, I think that the lithotripsy would be helpful for this kind of lesion in future. Next.
Absolutely, this would be a very good lithotripsy case.
Yes.
To re-expand that stent portion.
Yeah. And I tried to insert the 2.5 compliant and could not, next. And did the balloon anchoring, next. Next. Oh yeah, I inserted the 3.0 balloon at the LAD for anchor, and then impact the guiding catheter and close the region. Next. After that, I inflated the 2.5 compliant, next, and next. And because this was compliant, I think that still there's strong resistance, so I will try to insert the 2.5 NC in this time. And we know that the previous angio, and I think the circumflex vessel size is large enough. It looks more than 3.0. So I will apply the high pressure, the 3.0 at 12. And this is the NC balloon. Okay, easily passes now. Deflation. Okay. Nominal?
Nominal. 12.
I will open the distal region also. Deflation. And the most important thing is to open the proximal calcification. 20.
20. 20.
24. 4.
It's still not open.
Yeah, this is a small balloon, but it's well opened. Take a time and deflation. And we'll also inflate the 3.0. This is NC, 20.
20.
You can see that there's indentation of the LED balloon. Deflation. Okay, let's do kissing and check the image. Okay, 8.
8. 2, 4, 6, 8.
Okay. Deflation. I think that I should check the LAD and circumflex both with the intravascular imaging. There is new indentation in the LAD ostium. Maybe there's some calcium movement or the. Okay. Let's check the LAD first.
It looked like the balloon didn't expand fully, the ostium of the
Yes.
LAD or the
Yes, I
circumference.
agree. Yeah. But at the LAD, actually before the circumflex ballooning, the lumen was okay. So I will check the IBUS for the LAD again, and we'll decide to apply the bigger balloon So this is 3.0 and a little bit small for the LAD osteo. Yeah, this is prox LAD pulbe. There's luminal narrowing, maybe related to the calcium inside the stent, and also outside the stent.
So I think very probably the mechanism of the stent failure in this case is the underlying calcium. And now, even using a high pressure balloon, you cannot really gain a good luminal gain. And the calcium is so aggressive now, it's almost covering the ostial circumflex. So technically, I think it's feasible for PCIP, but of course, it's very prone to a recurrence of ISL for this particular case. I think this occasionally encounter similar scenarios. We did a very decent job of PCI again, but patients usually come back very soon, maybe within a year or less than 6 months. And then next time, come back with very aggressive ISL again with bifurcational tight lesions. So,
is there any value in finishing the LAD with a drug-coated balloon? Or do you think the underexpansion doom this stent?
In a couple of cases, I had quite good experience with IVL with shockwave.
No, that's what we said. I don't think they have it available.
But it's more limited if there are two overlapping layers of stent. For one under-expanded stent, it works much better than for two layers.
I think he certainly would have pulled it if it was available.
And now you could try to use IVL to blow up the calcium behind the stent. Probably we need more therapy to get the same result.
네, 잘 돼가요. You can see, can you please show the pullback of the circumflex again? This is the circumflex pullback. Yeah. You can see the ring calcification, very heavy plaque burden at the circumflex mid and the proximal. And you can see the heavy plaque burden of the calcification. Now I will do my best to open the calcification and then see with the.
Would anybody do atherectomy on these two limbs?
So the ostial sarcophagus is no good via bias, but distal part is, I think we can do the abrasion. To cross the ostial sarcophagus is just a bit risky.
Yeah, I think that the rotabulation a little bit, it can be a little bit dangerous because of the angulation of the circumflex osteo, and even there is a stent in the ostium. So I will do because I now know the vessel size and the morphology, I will apply the more higher NC and try to open the vessels. 2.5 again for the distal circumflex.
We'll go higher.
3.0부터 줘보세요. 3.0.
3.0.
Not worried. The vessels.
What is your next plan for the circumflex?
Yes. To open it
NC.
as large as possible with the NC. It was 2.5 before, and I'm inserting the 3.0 NC for the circumflex osteo.
Any concerns of losing those high obtus marginals?
Oh, I have concern about that also.
You showed us yesterday some of the missing branches yesterday.
20. Deflation. Okay. 24.
24.
26.
6.
Deflation. The patient has the chest pain. morphine 좀 주세요. Test again. Okay. The branch is alive yet. The patient has the chest pain now because already. And 2.5 한번 줘보세요.
Could you show us another projection?
Yeah.
This is some shortening of the vessel. Oh,
okay.
I want to see the whole circumflex artery territory.
Yep. This is the array view.
My first impression about the angiogram was it looks like a really, really high risk and a very difficult region. But I think you have a very skillful hand so far. Everything is just fine. Excellent procedure.
Yeah, test.
Test.
We'll open the distal region with a 2.5. The vessel size is not so large. 12.
12. Sorry.
Yeah. Okay.
12 again. 12. Cluster.
Okay. Can you please give me a balloon again? I think there are some problems during the balloon insertion. 2.5 NC 다시 주세요 같은 걸로.
Do you think it's time for you to give a puff? The patient is struggling a little bit before.
And my concern is the operation, so I do not want to dilate so much about the distal circumflex. But at left main, the vessel size is large enough, so I will apply the big balloon. This is 2.5 again. There's some problem with the previous balloon.
Because from the angiogram, the calcium distribution really will tell the risk because it's almost wise. It's now I can see it's biased towards the outer curve. It's not towards the current. You can see some haziness. So so far so good.
14, 16, 18.
Deflation. 18, 20. You can see, can you see the image? Deflation. In cine, it does not look very well, but in the stem booster image, you can see that the balloon is not inflated, not fully expanded. 20, 22, 24.
4.
This is booster image. Now I can see that stem is very expanded, deflation. Insert a little bit more. Okay, nominal.
12.
14. Okay. Deflation. Now the balloon is fully expanded. Yeah. 18, 20.
20.
24.
24.
Deflation. Check the angio smoothly.
Okay.
Small angio. Fortunately, all branches is alive, and I think that the lumen is much better now. I will check the IVUS again to confirm that the calcium.
In look at the asthma of the circ. There is some layer in the higher obtuse marginal branch. Was maybe there's some difference.
The wire already cut through the vessel.
Is that a hematoma? What do you think is happening there?
There could be some dissection, or it can be just calcium mass. Let's see what there is. Okay, 풀배.
In this IVUS imaging, the vessel size of the circ more than a 3.0, more than a 3.5. It means a very big vessel size with a heavy calcium. A lot of the break.
Yeah. You can see the break at the mid circumflex tight region.
You have to be more cautious in the asthma also. There is some looks like. This is a left main.
So could you bring the wire to the high lateral branch, and then if you can show us the pullback IVUS
from the high obtuse marginal?
Yeah, upper side branch.
But I think it would be something dangerous. I will not try. Yeah, and it will
rewire.
Yeah, it will not affect the patient outcome. Okay. The length from the distal landing to circumflex ostium is the 28. So I will use the 28 step. Will implant. I confirm that distal region is the proximal region, calcium break. And proximal region, there's a mass effect of the calcium. And with the balloon, I cannot further dilate, I think. I will implant the stent and with consider to further dilate with the big NC balloons. 3.0. 3.028. 예. 그리고 3.5 NC 주세요.
Achievement of the larger size of the stent area, but we have a caution. This is a heavy calcific lesion, so some more risk of the perforation during the high pressure balloon inflation. Keep in mind.
Yeah, I will not apply so high pressure, especially for the proximal complex lesion. It's a very perforation prone looking lesion. 3.5 NC, 3.5 NC please.
Which stent? 3.0 which stent?
Yeah, it's a giant stent. Giants. 3.0. But the distal vessel is large, but the lumen is just 2.8. And I will do under expansion of some low pressure this time.
I think the issue of such calcified distal bifurcation lesion is if you further expand the osteocert, you may compromise the osteo-LAD further. We can see on the angiogram the osteo-LAD diameter is smaller than before. And even so after you implant the stent.
Yes, so I cannot remove the calcium mass. It can happen. So I will try my best. Okay, let's see. Test. Okay. So I connect. Test. Okay.
So IVL is not yet available here?
Oh yeah, not yet. I'm so sad about that. Test. Test. 6, 7. 7. 7. 7. Test 10. 7. 8.
So what's standing strategy now? Is it the T or
I'll do
DK?
trying to do the reverse crush.
Reverse crush. Yeah. So mini
12,
crush.
14. Yes, mini crush.
12.
12. 14.
14.
Deflation. Let's give me 3.0. Okay, shall we test to see whether OM is okay? Small test.
Test.
Okay. Oh, luckily, the whole OM is surviving. Okay. But I will not apply very high pressure, especially at the with circumflex. This is 3.0 for further optimizing the circumflex osteo before crushing. Okay, 3.0, 20.
20. 20.
24.
4.
Not too aggressive.
Deflation. Okay.
There is some haziness at the outside of the circ stand.
Okay. Let's see. Yeah. Test. So check the flow. Test.
Test.
Then remove the circumflex wire, and we'll do nominal.
Nominal.
3.5. Yeah, this is 3.5 balloon.
12.
14 deflation. Yeah, there is some opening limitation in the radial steel. You can see. Yeah, nominal.
Nominal. 12, 14.
Yeah. 16 deflation. There's some operation, I think. Is it okay?
It's okay.
The patient has a chest pain with the main ballooning. Test.
Test.
It's okay. Yeah, nominal.
Nominal.
Please show us the angiogram.
14, 16, 18. Deflation. Yeah.
A little bit looks like some extravasation. Careful.
Okay, let's check. Symmetry, angio.
Angio.
I think it's not extravasation, but calcium.
It's just vessel is very weakened over there.
Yeah. You can see still the circumflex sand is not expanded because of the calcium, heavy calcification. Let's see the LAD.
I think there's a hematoma outside the stent.
Right.
Yeah.
Outside of the stent.
It looks larger.
Localized.
Yeah. It's contained. It's not extravasating.
Yeah, I will not do too much.
Because that is the hematoma. We add put the additional high pressure. It may be the propagate and more distally.
Yes. And here is the opening of the circumflex. You can see a stroke from the circumflex at the 5 o'clock. But it looks that the opening is well. So please give me another wire. I will rewire the circumflex, and we will evaluate the circumflex and consider the final kissing.
Do we need the final kissing in this patient? In the usual reverse crush technique, we need, but that one, in these cases, there is some hematoma outside of the stent, particularly in the osteoma of circ or osteoma of the LAD. You have to
Actually,
be more
I
cautious.
did not pull the stent so much of the osteum, so I think it's just done just like the T stenting. Yeah. Let's check the circumflex IVUS. 모빈 좀 할까? 언제 안 들어갔어요? 3mm 해주세요. 네. Yeah, this is the previous very tight lesion. Okay, further. Yeah, pullback. Distal edge. I think the scan is placed at the calcification. Not a very good position, but I think it will be acceptable. Okay. Here is a previous tightest lesion. And you can see that on the expansion and malposition of the stent because of calcification, and that's why the calcification makes a worse outcome. Okay. Oh, let's show
Please
the
show us
again.
the osteoma of circ. IVUS finding again.
지금 왜요? 다 하고 있어요.
하고 있는 건 뭐야 아파 죽겠는데.
원래 아파요.
환자분이 엄청 아프실 거예요. 거기 헤마토마가 생겨가지고.
Okay. The patient suffers a chest pain, giving some pain medication. Here's the osteo.
I have some suspicion in at the 1 or 2 o'clock in the osteoma of circ.
Yeah. Will show me again, osteo. That can be a dissection or the dissection to the opening to the OM, high OM. Yeah, I will check the spider view.
So Dr. Kang, you mentioned that you try to reverse crushing, but it looks like
yeah.
It looks like tap. So I don't
Yeah.
think you don't need to do final kissing actually.
Oh yeah, luckily
Yeah.
I think that I did a very good
I agree.
stenting. Yeah.
Yeah.
That's good.
for the patient safety.
Sure.
Yeah.
And definitely there is some hematoma.
Hematoma, yeah, that makes some hedginess.
Circumflex.
Just let it alone, and they prescribe the dual antibody therapy more longer time. And
yeah.
You're right. You didn't really bring it back. You brought it was more of a reverse tap than a true crush.
Yeah. But I think that the stem position is
which
very
is fine.
Good.
It's simpler.
Yeah. A little bit different from what I intended at first, but stem position is good. And there's a hematoma, and the lumen is okay. And I think that for the patient safety, about starting the procedure here, I want to ask your opinion to the expert panelists and moderators.
This is my personal bias. You are so skillful. You did every procedure from the beginning and to the end without any hesitation. And every step is a theological, wonderful procedure. Even though the lesion is a so high-risk patient, wonderful.
Thank you. Thank you so much. And this is a very difficult case of the circumflex ostium. And in our registry data, about 10% of the left main bifurcation patients experience the left main ISR. And usually we perform the PCI in 90% of cases, and 10% undergo the cabbage. I think that this patient, because the circumflex is not covered with the stent, and I'm trying to cover the open and cover the lesion with the stent. However, there's very severe calcification, especially from the outside compression, and it open as big as possible, but there's some hematoma and hedginess. But I think that I've cared the patient well, and after some time, with a long depth, and he will recover well. However, if the patient recurs again, and then cabbage would be a good option, I think. Because we always have the escape not to do very complex PCI for high-risk patient.
Still, we have a time.
Yeah.
5 minutes, or 3 minutes.
I think given the tools you had, this is the best strategy. In the United States, we would have lithotripsied both the LAD, ostium, and the circumflex. But you can only do what you have available.
Not available.
I have a question to Flaherty that if I apply the lithotripsy in this patient, I would apply the left main to LAD and left main to circumflex with the lithotripsy.
Yes.
And how long do you apply it? Is the patient stable during the lithotripsy?
Generally, they're short runs for the pulsations. You just leave the balloon up for the time of it's 6 seconds pulsation.
10 seconds and several times. Okay.
Any comment?
So there is another option before, of course, this happened, is to use the OPN balloons, which are up to 35 atmospheres.
We don't have those.
If they are properly sized, they don't really risk much of perforation. But, of course.
That's not available in the U.S. right now.
No, it is. It is, actually. We have it in our lab.
I need to order some then.
Actually, I totally agree with your opinion, because the first case, ISR was maybe the mechanism was geometric growth, but this case is definitely under expansion of calcification due to. So we didn't treat that kind of under expansion, especially ostium of LAD. So is that the patient have a high risk of re-stenosis. So if we can do that, the high pressure balloon should be applied at ostium of LAD. But right now, it's better to quit the procedure. Yeah.
But it may have been recoiled because there's a lot of external calcium. It may have been optimal at the time of the first PCI.
Okay, I will follow the patient for 6 months, 1 year, and next TCTAP, I will show how the patient is ongoing.
Yeah, Dr. Kang, the very wonderful, skillful, yes, PCI. Thank you very much. And again, I would like to back to the initial PCI. As I told you, in this case, yes, the site of the CX orifice is distal cell of the crossover, right? It is very lucky, yes, because you can easily pass the wire to the distal cell. But generally speaking, if there are tissue growth, sometimes coming from the metal carina, and only we can pass the proximal site to the through the CX orifice, right? At that time, if you dilate, the stent strut goes up to the main branch, right? And then if you dilate the left main to LCX, just coming back. So it might be very difficult. But in this case, we are very lucky and unlucky for the patient, yeah, right? But it's also depend on your skill for PCI. Yes, thank you very much. Any other question or comment? Yes, please.
Is that possible in this case that we doing only the dark-coated balloon to the circumflex and inside the LAD, and let's see what's going on, because we don't have shock wave and we don't have another equipment to break out the calcium?
Pardon? Can you speak again?
I don't think so.
Can you tell me again?
If we do only the dark-coated balloon in the circumflex and inside the stent of LAD, and let's see what's going on, is that another option for this case before we, if this is not a live case presentation in?
I'm not sure. They really had to aggressively balloon that and caused injury to the vessel. So I think a stent was necessary to secure the artery here.
I agree. I would stent. Yeah.
Yeah, so yes, I think I want to comment. So Dr. Akasaka mentioned, so in the first PCI, so even this circumflex is not compromised, I think it's better to do the kissing balloon inflation, because if the patient get the distal circumflex lesion again, so you have to reopen the side branch at the beginning. So you have to touch distal lesion and also retouch the left main bifurcation again. So I think I recommend it to do the kissing balloon at the very important left main.
Well, this is an age-old debate. That,
Then do you perform routine kissing for the left main crossover? For all case?
No, that's the beginning. So in the first case.
Yeah, but I believe in Dr. Hong telling me the Korean data suggests that leads to more injury than it does help, if it's not diseased in the first place. But many hold your opinion.
Okay. Yeah. Any other comments? Yes. I think this also the very important, Dr. Hong said, right? The eccentric calcium, if we dilate very aggressively, there are some risk of perforation. Therefore, we pay attention to the too much aggressive procedure, right? Yeah. Okay. Okay, Dr. Kang, thank you very much. Wonderful, yes, wonderful procedure, and congratulations on the success of the PCI. We learned a lot from your procedure, and thank you, the panelists, wonderful comment and the discussion. And I also appreciate my co-moderator, Dr. Hong, and also I appreciate the audience to join this session. Thank you very much for your kind attendance.
Thank you.